Good afternoon, everybody, and welcome to today's Romano round session. Good afternoon. I would like to welcome all of you who are here in the room, as well as those of you who are joining us by Zoom to today's session. We're very excited to have the speaker team ready to share what I think is going to be actually very interesting and novel to many of us here in the audience. I'm going to open with some housekeeping and then hand it over to Dr. Easton for introducing today's panel. Just by way of housekeeping, for those of you who are in the room, you are welcome to think about your questions during the course of the session, and we will carve out some time at the end for you to ask them. I'll be moderating the discussion at the conclusion of the session, combining both in-person questions as well as those from on Zoom. To our friends who are attending on Zoom, please feel free to use the Q&A function to enter your questions at any point in the presentation, and I will be sure to read them out loud to our panel at the conclusion of the session. Second, there will be an evaluation form for which a QR code is going to be available here on the screen. For those of you who are registered online, you'll also receive an email inviting you to complete that evaluation. That really does two things. One, it gives feedback to our speakers, but number two, it unlocks the magic of continuing education credit. We invite you to please do that for both reasons. They're both important. Thank you in advance for that. And then last but not least, for anybody who's here in person, if you didn't happen to notice, there is an amazing market happening right outside of this room until 2:30. I heard from a friend that the apple flavored fry cakes, don't shake your head at me. I heard from a friend that the fry cakes are amazing and you can get them with all kinds of toppings. For those of you on Zoom, I'm really sorry you're not here because it smells amazing. And the atrium is vibrant, full of local vendors, including folks from here at U of R who are trying to solicit you to sign up for all kinds of healthy things after you already eat the fry cakes. Again, not from personal experience. So without further ado, I'm going to hand over to Dr. Easton and to our presenter team for today. Thank you.
Welcome. Good afternoon, everybody. Welcome to Leveraging Computational Models and Digital Tools to Enhance Care for High-Risk Substance Use Disorder Patients. So I'm going to start by introducing our presenters. We have Dr. Myra Mathis. Dr. Mathis is an addiction psychiatrist and assistant professor in psychiatry. She is the division chief at the University of Rochester Department of Psychiatry. Dr. Mathis is a clinical leader who facilitates curriculum and didactic seminar development for clinicians and students in training as it pertains to becoming certified and or licensed to treat clients with addiction and co-occurring mental health. Dr. Mathis also facilitates and promotes trainees' use of translational science and evidence-based care to improve care of youth and adult populations with SUDS and co-occurring mental health. Dr. Mathis has won numerous awards for her compassion and dedication to mentoring students in training. She's also won the Healthcare Hero Award for her success in treating hard-to-reach patients in care. Dr. Mathis studies protective factors and resiliency and how that impacts treatment outcomes among substance users with co-occurring mental health. Dr. Henry Philofsky earned his BA in biology from Columbia University and his MD from Columbia University College of Physicians and Surgeons, where he won first prize at the 2018 Medical Student Research Conference. He has presented posters on bioinformatics research at multiple national informatics conferences, and he is first author of a forthcoming book chapter on placebome and neurology. Also noteworthy is that Henry started his career as a professional dancer at the Pennsylvania Ballet in Philadelphia and Ballet West in Salt Lake City before earning his BA in biology for Columbia University. He also worked in state-level public health advocacy on raising the age of tobacco sales to 21 for a foundation, including co-founding and being the steering committee of Tobacco 21 for Oregon, which was signed into law in 2017, is found by Oregon Health Authority to have reduced tobacco initiation from 34 to 25% among 13 to 17-year-olds. So thanks for that. Impressive. And then we have Dr. Pezzino. Dr. Tori Pezzino earned her doctorate degree from Pace University at and predoctoral internship from Rochester Institute of Technology. She has expertise in providing cognitive behavioral therapy, psychological testing, and cognitive remediation across schools, hospitals, and community clinics, and has worked with individuals with autism, psychiatric disorders, substance use disorders, and co-occurring medical conditions. As a predoctoral intern at Genesee Mental Health Center, she gained experience in family therapy, risk management, and crisis intervention. Dr. Pezzino is a T32 postdoctoral fellow at the Center for the Study and Prevention of Suicide at the University of Rochester Medical Center. Her second home is within Addiction Psychiatry Division, where she will perform her clinical trials. Her work focuses on using evidence-based digital therapeutics, such as an avatar-assisted rich CBT platform and biomarker research to advance the field as it pertains to the treatment of individuals with co-occurring substance use and depression. So without further ado, Dr. Mathis.
Thank you, Dr. Easton, for your very kind and generous introduction, and to Dr. Rosenberg for so expertly setting the stage for us, as always, at Grand Rounds. My job today is to really essentially tee up the next speaker. So that's what I'm going to focus on. Dr. Philofsky and I will be presenting on the use of causal inference modeling to identify factors associated with acute overdose risk in the URMC opioid treatment program. So we're going to start off by describing the opioid treatment program and then move on to our other content objectives. And that is really my role, to do the description. And Dr. Philofsky is going to take the rest. So I may move a little quickly in order to give him space to get into the meat of the presentation. So what is an opioid treatment program? This is just to set the stage and make sure we're all on the same page about what we're discussing. The colloquial term is, quote, a methadone clinic, which many of us have heard. It is a federally regulated clinical program that is specifically regulated for the administration of methadone for the indication of opioid use disorder. It also regulates the counseling that is associated with treatment of individuals for opioid use disorder. Medication dispensing in our clinic happens 6 days a week. Individuals present between 6 times a week and twice monthly, and we have 200 to 300 patients in our milieu on a daily basis receiving their medications. As an integrated clinic and a CCBHC, it means that in our opioid treatment program, which is distinct from others, we can provide treatment for all substance use disorders as well as co-occurring mental health diagnoses. There's a long history regarding that, but I'm not going to get into that today because we have other things to talk about. All right, so methadone, it is highly regulated and often poorly accessible. There are only 2 OTPs in Monroe County. There are many surrounding counties who are without methadone access. We're eagerly waiting the opening of 2 more OTPs at some point in Monroe County, but the regulatory barriers make that really challenging. And our program has been open since 1973. It is the longest tenured methadone OTP in our region. Prior to 2020, counseling was required for continuous medication access. It is the only medication in the United States where there is a federal requirement for counseling in order for a person to receive it. This was pre-2020. In 2017 to 2018, fentanyl entered the US drug population in Monroe County. This led to a highly variable and highly potent drug supply, marked increase in overdose deaths, and it was a driver of the need for increased access to methadone. The 2020 public health emergency that we are all very familiar with demonstrated that the safety of methadone, that there was safety in administering methadone without the requirement of counseling. So during the public health emergency, some of those regulations that tied methadone administration to counseling were relaxed, and data reviewing that time period demonstrate that it is safe to do so without increased risk in overdose for patients who are receiving methadone. So when we look at the effectiveness and safety of methadone, on the first side, we are looking at relative risk of mortality compared to patients who are receiving medications for opioid use disorder. And the light blue is all-cause mortality, the dark blue is overdose mortality. For patients who are discharged from a methadone clinic, Their all-cause mortality has a relative risk of about 2.3 compared to individuals who are engaged in care. And for patients who are discharged, their overdose mortality is about 3.1. The real significant difference that I want to draw our attention to is the risk of death due to overdose for untreated patients, which is above, the relative risk is above 8 compared to individuals who are engaged in treatment. And even compared to individuals who are discharged from treatment, the difference is 3 to 8. Through 2020 and beyond, you can see that small red line at the bottom. It shows overdose deaths due to methadone through the pandemic and across about 20 years. And what this lets us know is that that methadone remained involved in a small share of overdose deaths, even during the liberalization and increased access to methadone that did not require counseling. What does that mean for our clinic and our patients? I'm mindful because I'm eating into Dr. Philofsky's time. So patients were eligible for more take-home doses. That means they had more medications at home. They weren't coming into the clinic as often. Patients were not required to attend counseling visits, even though, as we know, with all psychiatric medications, there is a certain efficacy with a prescribing medication, and there is increased efficacy when you have medication combined with therapy. But this is the first time that patients were not required to attend counseling visits. And patients attending medication dispensing only could not be discharged for not engaging in therapy. This also meant that higher risk patients were entering our clinic population. Individuals who are using high potency, highly variable drug supply, they are not talking to our therapists, they're receiving medication, and we just have less of a handle on them. Our overdoses in our clinic increased in the context of this fentanyl use, and the impact on the clinicians was significant. We had difficult patient losses due to overdose deaths at rates we had never seen before. And there was an increase. This increased risk was being managed without the previous tools that we had used to address that risk, i.e., reminding folks that counseling is absolutely necessary and even a requirement to continue to engage in treatment. That particular tool was no longer accessible. So we asked the question, how can we use statistical modeling to identify factors associated with acute overdose risk? This question was asked because we wanted to support our clinicians in being able to manage the acute risk that they are now shouldering in the context of these regulatory changes. Our longest tenured clinician, Charles Brown, gave me some comments and positive thoughts for this lecture that I will leave with you as I hand it over to Dr. Philofsky. He said, discomfort is not the enemy, it is our new teacher. So the discomfort of these regulatory changes forced us to learn something new, and Dr. Philofsky will talk about those things. He also said that everyone communicates, but few people connect. And some of the data that Dr. Philofsky will show demonstrates how important it is for us to actually connect with our patients. Here you go.
So I'm just going to start by describing the population of patients that are treated at the OTP. This is the descriptive data for patients that were seen between the start of the public health emergency in 2020 and until June of 2024. You can see there's a rather diverse makeup, but that, for example, most of the racial and ethnicity breakdown of this population is Caucasian or African American, with some level of multiracial patients and others that identified as other, with relatively little diversity after that. And you can also see that the patient population is about 45 with significant variability, going all the way down into the 20s, obviously, and then all the way up to the 60s and 70s. This is the number of unique patients that are dosed every day in the OTP since 2020. And you can see that there's significant variability day by day because patients don't come in every day. And you can also see that it goes up and down based on holidays and things of that nature, and that there's significant seasonal variation. This is the number of patients that are dosed each month that are unique. So even though the number of patients who are dosed every day goes up and down, the number of unique patients every month has continued to grow since 2020, reflecting the need for this treatment. The numbers have also gone up annually until the last year when they went down slightly. Unclear if that'll continue. The genesis of this project was to try to make use of all the clinical data that we have when we're treating patients and to see what we can learn about the patients that we are treating from that data. Starting with overdoses, we get overdoses from the critical event reporting system. So the top line is the number of reported overdoses that were confirmed by the quality assurance staff. You can see that they really start to take off in the middle of 2022 and have continued up until now, but that there's significant seasonal variation. And these are 3-month rolling averages, by the way. The green line is all of the confirmed overdoses plus presentations to the emergency room for reasons that are related to overdose or alcohol consumption. And you can see that there's some mirroring of the trend, but not completely, and that the numbers are much higher. The line on the bottom is all emergency room or urgent care presentations by patients in the OTP population. And you can see that that's also much higher, but that the seasonal trend remains, which is something that's important to think about because we have the same staff year round, but the burden on the staff ebbs and flows, which is a difficult situation to be in. In just taking simple looks at the data, this graph shows the relationships for individual analyses of factors related to acute risk of overdose in the next 30 days. Each of these factors is based on the past 30 days. And the reason for that is that we are trying to find things that would be helpful to clinicians in real time in terms of deciding how to work with their clients. I don't think any of these findings would surprise people. No-shows to scheduled appointments appears to increase people's risk substantially. This type of analysis could only really be done after 2020 because previously appointments were required for everyone, whereas now appointments reflect a clinical need, which means that the absence of appointments due to no-shows reflects a clinical need that is not being met. So the information in the data changed substantially. You can also see that total appointments increases the risk of overdose. That likely reflects the underlying acuity of the patient's condition and that either the patient or themselves want more contact with their counselors, and so they're scheduling more appointments. Not that more appointments in and of itself causes risk of overdose. But one of the dangers of looking at this type of data is that you can find associations for almost anything if you look hard enough. So in an effort to try to get a little bit deeper, we created some causal models to try to learn a bit more rigorously about what might be going on in the clinic. So the drawing to the left is a directed acyclic diagram that is positing assumptions to guide a clinical analysis. So acuity is the dot at the top, which represents how much someone needs treatment. And as I said, we believe that that drives the number of appointments that people get, some of which that they will no-show to. Not showing up means they will not receive care. And as a result, we imagine they're more likely to use substances and that their overdose risk will increase. And we're modeling the interaction of it for statistical reasons we don't need to get into. The virtue of doing this is we can use something called do calculus to make a causal estimate of the effect of no-shows on risk of overdose without doing a randomized controlled trial, conditional on the assumptions we are making. And what we find is an interaction odds ratio for each additional no-show of about 4.6% increase in the odds of acute overdose in the next 30 days. Based on that model, I can also simulate what an intervention would do if we were to decrease the risk of no-show or decrease someone's no-shows and increase their completed appointments, essentially converting someone from a no-show to a completed appointment. And that odds ratio is 0.85, which is pretty large. The uncertainty is also not small because it's a relatively small sample of patients. The graph to the right is a 3D plot of the interaction. So the way to read it is the y-axis is the odds ratio. The axis going from northeast to southwest is total appointments. It's increasing going southwest. And then the axis for no-shows is the one going northwest to southeast, and it increases going more southeast. And what you can see is that as total appointments increase and the number of no-shows increase, the odds ratio goes down. Or the odds ratio increases, the no-shows increase, the odd ratios go down. But that was all based on one simple model. We can make that model slightly more complex by including more clinical data, notably missed methadone doses, as well as the level of dose stability of methadone. The dose stability being a pretty reasonable reflection of the acuity of someone's condition, because dose stability reflects the number of missed doses. And in order for the dose to go down due to missed doses, you have to actually miss a reasonable number of them, not just one. In doing this analysis, we find a standardized no-show odds ratio, so that's based on the standard deviations, about 2 no-shows, increases the risk of overdose by about 17% in terms of odds ratios. And we can also simulate the effect of reducing one of those no-shows with this slightly more complex model, and that reveals an odds ratio of 0.923, which is larger than the more simple model, but continues to be statistically significant and is in the ballpark of that. But there are still limitations to doing this sort of work when we can't actually intervene. But we can't run clinical trials on patients in terms of giving them methadone or giving them appointments. But we can do the next best thing, which is we can use the weather. So I'm not going to go through the figure on the right, but I downloaded the weather data from the Rochester airport for the last 5 years, and I defined what I thought of as bad weather. I'll just say this is my definition. There aren't actually like converging definitions of bad weather. Depends on where you are. And then I looked at whether or not there was bad weather preceding people's no-shows in the 4 hours beforehand or in the 4 hours before the typical methadone dosing window. And then in doing that analysis, having a weather-related no-show increases the risk of overdose by an order of 1.29. This is kind of a subtle point, but because weather is causing the no-show, this is an estimate for the direct impact of an additional counseling appointment on someone's risk of overdose based on the weather. So it's someone who may have actually wanted to come to their appointment, and we control for the number of appointments they miss not due to weather. This is an estimate of solely the effect of counseling in one appointment in the past 30 days, which is not something that people have really estimated in this population before. Just to put it all together, all of these analyses in increasing levels of complexity, including one where we use the weather as an intervention, Zeus would be proud, showed that increasing the risk of no-shows increases the risk of overdose, and decreasing the number of no-shows decreases the risk of overdose. These are all observational estimates. That comes with its limitations. But on the whole, our goal is to try to find out the impact of the work that clinicians do in our clinic. And even in one clinic with a relatively small population, we can earn an awful lot. Thank you to Helen and Dan Mang, as well as Ian Saro, and the Q-Core and the QUIP teams for pulling the data to allow us to do this analysis.
Thank you. Good, yeah. All right, so good morning or afternoon, everyone. My name is Tori Pezzino. Today, I will be sharing some information regarding a digital tool that we are beginning to employ at Strong Recovery called Rich CBT. This is a digital avatar-assisted CBT platform designed to engage individuals with co-occurring substance use and mental health issues to improve treatment outcomes such as symptom reduction as well as treatment adherence. So as we know, SUDs or substance use disorders are a significant public health concern. It was reported in 2023, around 27.1% of adults ages 18 to 25 reported a substance use disorder in the past year. This was more than any other age group. And over 50% of young adults with a substance use disorder reported at least one co-occurring psychiatric disorder. This age group is at higher risk for psychiatric disorders compared to other age groups. And some of the most common disorders reported or symptoms include depression, anxiety, suicidal behaviors, and substance use. So what has helped in the past? Well, cognitive behavioral therapy shows that it has been effective across numerous psychiatric disorders across the globe and has been used as a target intervention for individuals with SUDs and comorbid mental health disorders. So given the risks of depression, suicidality, and disinhibition tied to substance use, interventions targeting co-occurring disorders are urgently needed, yet barriers exist in trying to reach this goal. So barriers may stem for a variety of personal or logistical reasons, such as stigma to receive treatment, lack of motivation to attend treatment, co-occurring mental health disorders, and more. Despite the need, fewer than 20% of individuals with substance use disorders receive treatment, and residential dropout rates can exceed up to 70%. So we must ask, what are the potential solutions? Well, digital tools may offer scalable solutions, especially for young adults who are confident and comfortable with technology. It allows them to relate to this venue and foster a sense of control within their treatment. We also know that within treatment, therapists' drift may be present, even when a therapist is following a manualized treatment, receiving frequent supervision, and having frequent fidelity checks. And as mentioned previously, with sometimes overdose and death, therapists can be exposed to vicarious trauma, which can lead to compassion fatigue or burnout over the years. So digital treatments are very much needed. Digital therapeutic platforms, they can be scalable, they can be user-friendly, standardized, and can assist clinicians not only in improving outcomes, but also making access or making care more accessible. So adapting CBT approaches into technology can overall address global mental health in clinical settings, hospitals, and schools. So can we improve treatment outcomes using advancements in technology, and how do we do that? So with Rich CBT, it's a new digitized avatar-assisted version. This tool is used to augment the therapy experience, not replace it, and is an integrative avatar-assisted platform that uses evidence-based cognitive behavioral therapy to concurrently address substance use, aggression and conflict, as well as negative mood symptoms. So within this platform, there are 12 different modules that address certain topics. So following a manualized CBT 12-week program. You can see on the right there what is included in some of the modules. And this CBT component uses ideas such as functional analysis, so identifying thoughts, feelings, circumstances surrounding drug use and aggression, providing psychoeducation on the interaction of them, as well as providing skills training, so unlearning and replacing old habits associated with drug use, and learning and relearning healthier skills and habits. And here is a side-by-side of just an example of what the digital platform may provide and treatment as usual may provide. So now I'm actually going to show an overview of what it's like actually interacting with the platform and what the client sees. So one second. As you can see, the participant or the client can customize an avatar, and this avatar is going to be the coach that is going to bring them through each of the modules. Okay. And then here are some additional features. So as you can see, they create a user profile, and then there is also progress monitoring between sessions, and it provides a visual representation for the therapist and the client of their self-reported symptoms from week to week. And then after clients are done completing their coach as well as the user profile, they then complete weekly self-report questions, which you will see right here. And so these are weekly breathing check-ins. So this allows a clinician to track mood and usage patterns on a weekly basis prior to the core intervention being delivered. And then clients interact with an avatar-guided CBT module targeting mood and substance use. So here's a short clip of what that experience looks like.
It's important to start to recognize some of the triggers in your life. That is, triggers to use and triggers to lose control of your emotions or temper. Scale each trigger based on how much they tempt you to use your substance of choice. Friends. Thank you very much for sharing your triggers with me. It really means a lot that you're taking the time and action to improve your health because you are worth it. Remember that avoiding triggers is the most helpful step you can take. But we both know that it's not always easy or possible to avoid things. So, please consider using some coping skills that can help you get through some of those challenging situations. Let's practice one right now. I'll guide you in practicing a mindfulness activity. If you're alone, practice this right now. If you're not alone, merely think about it to yourself quietly. Stand still or sit down and remain calm. Count slowly from 1 to 10. Thank you again for your time today. You really did a great job. Congratulations, you've completed this topic.
So as you can see, the modules include built-in positive reinforcement like rewards and gamified feedback to increase engagement. They also complete a quiz at the end of each module. And this is to rate their knowledge that they acquired during the session, as well as if they practice that coping skill and if they perceive that coping skill to be helpful. And again, this is used within the therapy experience. So then the clinician can also introduce other coping skills and debrief with the client after. So currently we're getting ready to start a phase 1 randomized control trial using this platform, but we have piloted this out with various populations to assess perception and satisfaction using the platform. So 2 studies in particular, Dr. Burberry et al. Examined the satisfaction results using this platform in an inpatient chemical dependency unit. Overall, about 90% enjoyed interacting with the platform. The customization did differ across age groups, with older groups preferring more of a default character versus wanting to actually customize a character, versus younger groups who did enjoy the customization aspect. And then 100% rated that they believed the experience was rewarding. Another study with Dr. Crane et al. Examined veteran population preferences. And what was found were females significantly preferred military avatars versus civilian avatars. And there were no difference for male participants. So this somewhat aligns with therapist matching, promoting therapeutic alliance for some participants. And majority of participants preferred a 10-minute session, then followed by 11 to 20 minutes, which is also consistent with our research and how often or how long they'd be using this platform in session. One of the most recent secondary analyses we conducted examined 99 young adults with substance misuse and self-reported depressive symptoms in a large urban university setting. We examined if they reported any symptom reductions over 2 brief sessions, as well as how they rated their engagement and alliance with this platform over the 2 sessions. So what we found was a significant drop in substance use between sessions, particularly with alcohol. Around 23 participants reported reduced drinking by session 2, and higher depressive symptoms did correlate with the number of sessions participants would engage with the Rich platform. And we also found with the pre-intervention Rich weekly questions that there was a significant reduction in ratings of substance use, feeling less hopeless or down, feeling less stress, and a significant increase in rating their practice with the coping skill taught and perceiving that coping skill that was taught to be helpful. Regarding engagement and alliance, there was a reported increase of engagement and usability from session 1 to session 2, with no significant difference in alliance. But there was an overall trend upward with rating alliance, and that is pretty consistent with research, as working alliance is usually assessed over 3 or more sessions versus 2, but the general trend upward is great to see. So our hypothesis is that individuals with higher depressive symptoms and substance use will report more significant reductions. So regarding strong recoveries patient population, some of the most frequent co-occurring symptoms reported include depression, anxiety, and trauma. So when patients display more significant mental health symptoms, they can be referred to embedded mental health treatment, which means they receive treatment for substance use as well as mental health. This was a small cohort of embedded mental health patients from last year's pre-doc intern cohort that they worked with. As you can see overall, the PCL5 is the light blue color, the PHQ is the pink, and the GAD-7 for anxiety is the green. So regarding that smaller cohort, most of the participants are rating moderate anxiety and depressive symptoms with higher trauma symptoms, indicating that they would benefit from PTSD treatment. And then additionally, within the predoctoral intern cohort at Strong, they complete scholar projects where they had the option to incorporate digital tools into their practice. And we had 3 interns that did want to do that, one being a DBT group, a Spanish-speaking CBT group, and a pain management group. So as you can see, among all 3 groups, the blue is the pre-treatment and the pink is the post-treatment. There was a reduction in self-reported symptoms of craving, degree of use, anger, conflict, feeling stressed and depressed overall. And there was an increase in practicing those coping skills and finding that coping skill to be helpful over time, the more they engaged. Of note, the pain management group was a 3-module session. The Spanish-speaking CBT group spanned around a little over 12 weeks, and the DBT group was a 6-week session. So the interns were able to incorporate this device and then also add in their own homework or exercises that they found useful. So for future directions, thus far, findings suggest that clients are finding the avatar-assisted sessions to be helpful, relatable, and increasingly usable. Digital CBT platforms could fill major gaps in mental health access for high-risk groups, and it's a step toward tech-enhanced, accessible behavioral health care that meets young people where they're at digitally, emotionally, and behaviorally. Regarding the future of psychology and tech, there is potential for this research to be coupled with AI, wearable technology, or biomarker data. Our hope is to objectively monitor behavioral health progression and treatment, deliver more personalized and on-demand interventions that can aid the patient in between clinic visits, or even detect when an individual may relapse. So thank you very much to our NIH-funded teams, my mentors, the developer collaborators. The Rich CBT platform was developed by Dr. Easton and colleagues at RIT and the Working Man, and continues to evolve today.
Thank you so much to this very expert team. Dr. Mathis, are there any closing words? Not to put you on the spot in front of a large audience.
Okay, I was actually thinking about this, so thank you for asking me
You
to,
don't have to. All
but I did have thoughts.
right, go for it.
Thank you. Okay, so I just wanted to highlight in particular that overall what this presentation shows is the use of both computational modeling, but then also digital tools to directly impact the care that we are delivering patients. And so as a different way of approaching the Romano rounds, where we've often thought about models of care or systems of treatment within our clinical programs, this is looking at ways that we can be innovative in the use of data and digital therapeutics to improve the evidence-based treatment that we're providing our patients. So a little bit of quality improvement, a little bit of research, and what we hope to be a really strong clinical impact for our patient population. And we welcome your questions.
What I really would call this is a smorgasbord of awesome. That's really what I would call it. So I'm going to look first here in the room to see who might have questions. You have a question? Julie Actel has a question.
Thank you. That was absolutely fantastic. I have a question about the first study and the results that you found. Did you review those with the clinicians, and have they put those into practice? And also, has it caused them to feel increased worry about no-shows and the weather?
So thank you for that question. Everyone is hearing this for the first time, so I look forward to receiving lots of questions about this when I return to the clinic. But also, I think you raised an important point, and it's something that Dr. Philofsky and I have talked about often in thinking about how to frame this, that we already know the mental load and burden that overdoses has on our clinicians and our patient population. Both the significant reporting, but also that felt sense of responsibility whenever we have an adverse outcome that could be preventable, the thoughts that clinicians have about the care that they've received. What we do hope is that this will allow us to have some more standardized ways of approaching those incidents that can relieve some of that additional mental load from our clinicians, that there's a shared understanding that this is not an individual person's risk or clinical decision-making load to bear, that it actually is it's a phenomenon happening across the clinic. And so my hope is that clinicians may personalize this a little less, because the data is showing that the phenomenon is happening in a broad way, and that we can have systems in place that support clinicians in their decision-making. I think what it also demonstrates is that naloxone distribution is important, that it has a meaningful impact in our patient population. And some of the reviews that we've done and some of the feedback that we've gotten from our quality team about making sure that we are documenting every time we offer and hand out naloxone, that really matters. And our team does an excellent job of doing that. So, hey, strong recovery, like, We're doing great. Keep doing the awesome things that you're doing.
Thank you. We have another question down here. I'm coming. My legs are short.
Thank you for that presentation. It was just amazing to hear the clinical, the research, the data, all of it coming together. My thought with that awesome question was also about whether there's benefit to empowering our patients with those data. So not just our clinicians, but really making it a partnership. And it struck me too that that type of rating could be so cool within the rich platform. So thinking about them tracking their adherence and taking ownership of that. So thank you. That was great.
No, I agree with you. I think one of the motivations of this project was to be able to empower clinicians to communicate clearly the risk that comes from decisions that they make, and the benefits of engaging in treatment. And that's one of the things we hope to share with them.
I would love to pick on the weather also for just a hot second. I am intrigued with the personal definition of bad weather. Thank you for just owning the bias. Some of us really love all of those elements, but really don't love other things like beauty, sunshine. No, I'm just kidding. But the weather is interesting and certainly out of our control. What I'm curious about though has there been thought about offering some sort of in the moment option to convert to a telemedicine visit in the instance where weather is prohibitive in terms of patient travel? I did wonder about whether we have any experience in doing that pivot and whether that could help reduce the deleterious impact of bad weather in the Rochester area.
So thank you for that question. We have not used Dr. Philofsky's definition of bad weather to inspire the conversion from in-person to telehealth. But when there are usually sort of like weather warnings, often when we're all on high alert, and we do offer telehealth conversion of appointments. I think this past winter was a bit more challenging than others. This past winter was not included in the data. So I don't know, like maybe if we get another load of data from the Q Core and we might be able to see if that conversion assisted. But yes,
yeah,
it's an important thought, and we may need to publicize Dr. Philofsky's definition of bad weather to help us make that decision.
Yeah, or just, feel your way through it, but that's fine.
We do
have a question for Dr. Pezzino that came in online. I think it is mostly for Dr. Pezzino. Do you feel patients will be more honest and forthcoming about their cravings with the digital platform versus a human therapist, particularly for folks who are more accustomed to that digital interface and more comfortable with screens?
Yes. Oh, sorry. Yes. Thank you for that question. There has been research that has shown that patients are more comfortable with technology and disclosing with technology, specifically because of confidentiality reasons. So the hope is that they will be more honest with that. We can't control it completely, but if they are more honest with the platform, that we then hope that they will be more honest with their clinician as their clinician's able to review that data with them. And it could almost be a bridge or a step in the right direction to developing that trust and rapport. But we can't necessarily predict if they will be completely honest.
It also sort of underscores the importance of using the digital technology as an augmentation to additional psychotherapy and not as an either or, that those things really can and should be working in partnership.
Absolutely.
Awesome. Thank you. Anyone else in the room with questions? You're pointing to me. Oh.
Hey, thank you. Ooh, really loud, really cool stuff. I had some questions about the modeling. Specifically, it seems like a lot of the variables would have a decent amount of multicollinearity, which affects models like that. Just kind of wondering like how you guys dealt with that, just especially if this is going to be used for predictions. And then also, this is close to my research interest, so you guys tried like a decision tree or like a random forest, especially if this is going to be clinician facing, right? Like what are the steps that lead to risk? Anyway.
So this is going to be a very in the weeds answer for a lot of people, but to clarify a couple things. The first is the goal of these analyses was not to predict anything. The goal was to measure. So no, I didn't use a tree-based model or a random forest or a neural network because that wasn't the purpose. I have done those things with much larger numbers of variables. It doesn't work that well because the base rate is just so low. To your other question about multicollinearity, I measured it for all of them. The only place it was a problem was the first model, and that's why we estimated it with the interaction term.
Cool. Yeah, thank you.
Okay, just speaking as someone who always misses the forest for the trees, you see what I did there? I do just want to give a shout out to our departmental trainees. This level of conversation is very humbling to me because I really have no clue what you're talking about. However, I'm very grateful that the next generation of psychology and residents are coming to the field equipped with a lot of smarts to be thinking about these models and hopefully to further the literature. So thank you. Thank you to our trainees. Any other questions in the audience? Otherwise, you get bad jokes from Dr. Rosenberg. Ending on that one. Thank you so much, Sean. Well, with that, I will say thank you to our team of presenters. Thank you to all of you in the room and online. Thank you for your engagement. Please don't forget to fill out the evaluation and have a great afternoon.
Yeah.